Today we are covering electrocardiogram basics, focusing on how the NCLEX will test your ability to recognize a rhythm and, most importantly, act on it. Let's start with the baseline, normal sinus rhythm. On the exam, you'll see a strip and need to confirm it has all the right components. There must be a P wave for every QRS complex, indicating the impulse started in the SA node. The PR interval, which represents the travel time to the ventricles, must be between 0.12 and 0.20 seconds, or 3 to 5 small boxes. The QRS complex, showing ventricular depolarization, must be narrow, less than 0.12 seconds, or under 3 small boxes. Finally, the rate needs to be between 60 and 100. If any of these are off, it's not normal sinus rhythm, and you need to figure out why. A common exam question will show a rhythm that looks mostly normal, but has a PR interval of 0.24 seconds. This is a first-degree heart block. The key here is that it's typically asymptomatic and requires monitoring, not immediate intervention. Don't fall into the trap of choosing an aggressive action when none is needed. Now, let's talk about a rhythm the NCLEX loves to test, atrial fibrillation. You will recognize this by its irregular rhythm and the absence of clear P waves. Instead, you'll see a chaotic baseline. The exam question will hinge on whether the patient is stable or unstable. If the patient is in A-fib with a controlled ventricular rate and is asymptomatic, the priority is medical management, likely involving anticoagulants to prevent clots and beta blockers. However, if the patient has A-fib with a rapid ventricular response, or RVR, and is showing signs of instability like hypotension or altered mental status, the priority action is synchronized cardioversion. The test will try to trick you by offering defibrillation as an option. Remember this key phrase: A-fib gets the sync. We only defibrillate for pulseless, life-threatening rhythms. This brings us to the most critical rhythms. Ventricular tachycardia, or V-tach, appears as wide, bizarre QRS complexes. The absolute first step is always to check for a pulse. This is a classic NCLEX trap. If there is a pulse and the patient is stable, you might use amiodarone. But if there is no pulse, you treat it exactly like ventricular fibrillation. Pulseless V-tach and V-fib are functionally the same on the exam. Ventricular fibrillation, or V-fib, is a chaotic, quivering line with no discernible waves. There is no cardiac output, and the patient is in cardiac arrest. There is only one priority action, and you must know it: defibrillation. This is the single most important intervention. The mnemonic to lock this in is simple. If it's V-fib, you defib. Don't get distracted by options like starting CPR or giving epinephrine first. While those are part of the ACLS algorithm, the definitive treatment and the answer the NCLEX is looking for is immediate defibrillation. To summarize, identify normal sinus rhythm as your baseline. For arrhythmias, assess the patient first. Is there a pulse? Are they stable? For A-fib with RVR, think cardioversion. For pulseless V-tach and V-fib, the answer is always defibrillation. Knowing these key differentiators is critical to passing your exam.